Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/QQZ. This activity is supported by an unrestricted educational grant from AstraZeneca. AstraZeneca has had no involvement in the selection of the speakers, the development of the activity, the agenda, or the materials.
Everybody, thank you very much. I hope you were coming to see us rather than just the free lunch, but I would like to make the free lunch worthwhile. It's a really exciting talk to give you today about harnessing the power of the urine albumin-creatinine ratio to shape the future of CKD management. My name's Kieran McCafferty. I'm a professor of nephrology down in London in Barts Health, and I'm joined by an absolutely fantastic leaders with me in this seminar. Maria Jose Soler, who's a professor of medicine and head of clinical nephrology and the dialysis unit in Barcelona, and Professor Kai Schmidt-Ott, who's professor of nephrology and head of nephrology and hypertension at the Hanover Medical School in Germany. Perfect. So over the next hour or so, we'll be looking at all the different aspects of proteinuria measurements and the relevance of that for our current and future clinical therapies. So we're talking about the untapped potential. We'll be looking at the impact of proteinuria, the association of proteinuria with poor outcomes, looking at the patient's journey, and then what we really want to do is have some time at the end for questions, both that we can answer and also we can maybe have a discussion, because I think that's the most important thing, because I don't think we know all the answers. So we're going to identify the role of urine albumin-creatinine ratio as a multifactorial marker across all the aspects of CKD. We're going to look at the association of proteinuria and increasing progression of renal function and cardiovascular disease, and look at the clinical profiles of patients who might maybe benefit from these new therapies. So we thought a lot about how do we address the problem of proteinuria, and we thought of what are the metaphors that we could use. So what we thought is, when we're thinking about proteinuria, we thought about the car and how we drive along, but cars don't break down overnight. And so we've got lots of opportunities for cars to try and intervene to prevent them breaking down. So this happens slowly, and so we need to be looking under the bonnet to see what's happening, and often we don't until things are too late and the car breaks down, and we can see the damage has been unfolding for many years. So we had lots of opportunities to intervene to stop our car breaking down. In more fantastic AI-generated images. If only the cars had a warning light. So, to be honest, whenever I have a car, there's always 15 warning lights, and I never know what it is. But if they just had one warning light saying, check your kidney function, consult a doctor, take your tablets, dip the urine, check the oil, I guess is the metaphor for dipping the urine in the car metaphor. And the reason for that is, proteinuria is the earliest form of, is often the earliest sign that the kidneys are not working that well. This is a classic diagram showing that proteinuria starts first, and it starts for many, many years, potentially, before the GFR falls. And if we look at kind of the classic way of, if we were diagnosing CKD based on a GFR, so down to when a GFR is 60, we might have, the patient could have had CKD for many, many years and could be at risk, and we're going to hear about the risk of proteinuria over the course of many years, all this wasted opportunity that we could get the patient diagnosed, get the patient coded, and potentially get patients on medicines that might help prevent them ending up on dialysis. So we have an alert in our car saying kidney function below 50%, go and see your primary care physician, have your tests done to confirm your kidney function. But, by the time it gets to that, we may already be 50% of the battle lost, and we're all fighting a massive battle against progressive chronic kidney disease to prevent the devastating consequences of kidney disease in the form of early cardiovascular death and dialysis. And so how do we test proteinuria? Well, we're not very good at testing for proteinuria, and reassuringly, no matter where you look, we're not that good at testing proteinuria in US, Spain, Germany, and we brought out, because we're in Scotland, we brought out some Scottish data. But on the whole, we're quite good at testing for blood tests, but not good for testing for proteinuria, and that's the first abnormality often that happens. So if there was one message that we want to take away is how do we encourage people to test proteinuria early? Obviously, at the start, 15, 20 years ago, we used to test for proteinuria by 24-hour urine collections. It was really difficult. And proteinuria, PCRs and ACRs helped adjust for the urinary concentration, really helped us test for proteinuria. But then there was this whole thing of like, oh, it has to be early morning. And yes, early morning is probably better. But, any urine sample is better than no urine sample, and patients come into clinic saying, "Oh well, I can't do urine tests because I'm told first urine in the morning," and we miss the opportunity to diagnose with CKD. So I think we shouldn't let the enemy of the good be the enemy of the great be the enemy of the good, in the sense that we don't let we want to just get as many proteinuria tests done and not demand the best one possible. Why? Well, we can diagnose CKD by doing a proteinuria testing, and then we can get code patients who tell patients they've got CKD. We know that patients who are diagnosed with CKD and coded for CKD are more likely to be on ACE inhibitors, are more likely to be on ARBs, more likely to be on MRAs and SGLT2s than people who aren't coded for CKD. And by delaying this diagnosis, by delaying this treatment, you get increased risks of events in terms of increased CKD progression, increased chances of kidney failure, and increased chances of heart disease. We know that our patients with significant chronic kidney disease are more likely to die of heart disease than ever end up on dialysis. So what should good CKD care look like? And so no talk on CKD is complete without the heat map. And so, we want to be thinking about how do we test for CKD? And I know you all know this, but, I would say a kidney health check is a GFR test and a urine ACR test together. And that tells us both the diagnosis and also the risk of renal progression. And I specifically looked up here because actually these patients probably don't come and see nephrologists. These are dealt with in primary care, and we need to really be engaging with our primary care colleagues to make sure they understand the benefits of testing, coding, and initial treatment of patients with CKD. So I would like to make the point that CKD is important for screening. It's important for diagnosis, and we diagnose CKD by evidence of proteinuria that's chronic, so for more than 3 months. We can risk stratify patients into risk of renal and cardiovascular protection. Where we're all here is that once we get patients proteinuria, we can then put them on the medicines that are hopefully going to keep them alive and off dialysis. And then we can monitor patients. So we can say to patients, when we put people on the medicines, we can say, look how much your proteinuria has fallen. I know you're on 5 more medicines than you were 2 months ago, but hopefully your proteinuria has fallen, and that will reassure them that all the medicines they're taking are doing them good. So we want to recognize it early so that we can treat it. And with that, I would like to welcome one more question. I'd like to ploy on and welcome Professor Maria Jose Soler to come and talk to us about the impact of proteinuria and identifying its role as a key driver of CKD progression. Thank you very much.
Thank you, Kieran, and I will try to convince you why we do not have to miss an opportunity to look for the proteinuria and to spread this knowledge to our primary care doctors. Why do we need to measure proteinuria? Because it's a risk, and we should identify this risk in our patients. So when the warning, let's go again to the car. When the warning signal appears, what happens next? What's happening next? So when proteinuria starts, there is a decrease in cardiovascular death. And when with 30 milligram per gram, no, it starts it increase, as you can see here. It starts at this increase and 5 milligram per gram. So when people ask me which amount of proteinuria do you want to your patient, what you will say? 0 if we can. 0 if we can. So let's go. You open the hood. How bad is the damage? The damage is really good. The problem is that we do not open the hood. Why? Because the proteinuria is silenced. Do you have ever seen any patient that comes to you and say, I have kidney pain because I have proteinuria? Never, never. So when you open, how bad is the damage sometimes? So the damage may be really, really bad. If my proteinuria is around my albumin-to-creatinine ratio 300 to 700, how is the decline and how is the prognosis of my cardiorenal prognosis? Is worse by 3.53. And if it is higher, this question was not good answered before. If it's higher from 700, my cardiorenal damage will be, hospitalization will be 5.48, will be increased. GFR decline, if it's lower, 3.1, and if it's higher than 700, it will be 5.5 per year. What about cardiovascular events? If it's lower, 2.3, but we know that it starts when the albuminuria already starts to increase. And if it's higher, 2.9. So, and mortality is the same. So as less albuminuria my patient will have, my patient will be with less risk of cardiovascular disease, of heart hospitalization, and renal hospitalization, and mortality. When the engine struggles, the whole car suffers. So, what about the patients that have albuminuria higher than 300? This nice study published in JAMA 2 years ago demonstrates that if you have a higher albuminuria, you will have, again, high risk of mortality, independently. If you are older, you will have more, but all of the patients, cardiovascular mortality, myocardial infarction, stroke. This is really, really important because neurologists, doctors, do they know what is albuminuria? Do they know how to test albuminuria? We now are in the point of cardiologists that they already know and they do not lose the opportunity if they are visiting a patient. But when you have one stroke, they are 30–40% of the patients that they have diabetes. Do they check albuminuria? No. So they do not miss the opportunity also to check. And hospitalization, acute kidney injury, altered blood pressure. So we need these patients, vascular arterial disease, we need to check to decrease the risk and improve the quality of life of our patients. We do not diagnose, we will never treat. We will not treat, we will never be able to reverse. So at that time, and sometimes the patients came really late because albuminuria was not tested before, the car broken. And do you know when it will be broken? How long the car will stay alive? No, we have some kind of formulas that we can predict when the car will stay alive, but we do not know. And this is a really nice old paper published, but I like a lot this paper because it was compared the patients with diabetes. If the patient only has diabetes, here you can see the risk of mortality after 10 years of follow-up. If the patient has diabetes and albuminuria, it increased by 17%. In case of diabetes and only decrease GFR by 23%. But if the patient has diabetes and both albuminuria and decreased GFR, 50%. This is the patients that we used to visit in our outpatient clinics. So how can I say to my patient, you have 50% of the risk of mortality in 10 years. So now we can diagnose early and try to prevent this. So can we still change? My question is, okay, you are giving all bad news, Dr. Soler. So if I diagnose that, can I do something? Can I change the trajectory of our patients? Sure. If we are able, this is a nice study by Tangri, that if we are able to decrease by 30% the proteinuria, more than 30% the proteinuria in our patients, in 10 years, we will decrease the kidney outcomes and the cardiovascular outcomes. So now is the time for us, the nephrologists, to help primary care and to take care of these patients in benefit of not ourselves, in benefit of our patients, that for sure they do not arrive to stage 5, a lot of them, because they die on the way. So we are now able to do that. And this is extrapolation of data from DAPA CKD. So you will say, okay, Dr. Asler, but you were telling that it's worse to have higher levels of albuminuria. When I should start? Should I wait until I diagnose or until the patient has 1 gram of albumin-to-creatinine ratio? Or should I start earlier? So this nice study demonstrates, it's an extrapolation of the study that shows that if you start earlier, you enlarge the years out of dialysis. And what's the worst outcome that could have my patients? For me, the worst nightmare that I have as a nephrologist, because we visit a lot of patients on dialysis program, is that I end up on dialysis because my quality of life decreased and my mortality increased. So, in summary, what we have to do is to start as early as possible in our patients, diagnosing and treating them for avoiding the progression of chronic kidney disease. The next question that is for Professor Kai is, who are these patients and how do we identify them in our daily clinical practice? The floor is yours.
And with this, I would like to go a little bit into clinical practice. And the title of my talk is The Overlooked Patient. And I would like to ask you, have you ever seen a patient where you thought CKD has been overlooked and a lot could have been done in the past? And I think if you're a nephrologist, every one of you will have a lot of these examples. And I just want to show you a few examples to illustrate the real problem that we have. The patient that we miss is often sitting right in front of us. I think we are quite aware of that, and we do not see the albuminuria. The patient may be asymptomatic. Kieran said it earlier in his talk, and nevertheless, there may be a severe and significant issue. Of course, we have many parameters to stratify our patients. This is why we're doctors. We're not machines, right? We're not saying, let's look at GFR and albuminuria and that will tell us all. We need to look at the entire spectrum and the entire picture. And looking at these pictures, the situation becomes very complex. And obviously, we have some patients with a very low risk. For example, if I have a patient with hypertension-associated CKD with a low-grade albuminuria, many of you would agree this patient probably has quite a low risk, but I want to maintain the hypertension well controlled, and I want to control progression of albuminuria over time in this patient. The same, and I think most of you know this, when you treat a minimal change disease patient to target and get them into remission, then they have a low risk of progressing. However, when FSGS or minimal change disease maintain active over time, there's a very high risk that they will progress to aggressive forms. Similarly, the same may be in IgA nephropathy. If we have a low proteinuria, if we have a well-controlled hypertension, the IgA nephropathy may be stable over years. Nevertheless, if we have high-risk IgA with histology that's comparable with this, or if we have high-risk IgA with uncontrolled hypertension or high degree of proteinuria, of course, these patients will quickly progress. So looking at the entire patient is important. And again, coming back to the car analogy, every car is different, and I think even more, every patient is different. So we should look at proteinuria in a differentiated way. So let's get to two cases which I brought to you. And this may be a very familiar case to many of you. 63-year-old male comes to your outpatient practice. They have a medical history of a long-standing, he's 63 years now, has a long-standing medical history of type 2 diabetes and hypertension, has dyslipidemia and obesity, and he presents to you in essentially a poor condition, has leg edema, reports fatigue upon exertion, has poorly controlled hypertension, and looking at the blood pressure, it's 168/94. We have a creatinine of 2.7, GFR is 27, potassium is 5.4, UACR is 800, so we make a diagnosis of CKD G4A3. Okay, why am I showing you this case? I'm sure you're very familiar with this case. Let's look at the history of this patient. Today we have 2026. In 2018, the patient was seen, eGFR was 78. Blood pressure was poorly controlled. Then the first UACR testing was in 2019. Was 110, indicating A2, UACR, albuminuria. Nevertheless, blood pressure maintained poorly controlled. He was on suboptimal therapy. Then he had several instances where UACR testing was not repeated. In 2021 and 2023, he had 2 additional measurements showing an increasing trajectory of UACR. And if you look at the same time at the trajectory of the eGFR, you see how the eGFR is decreasing over time. So we have several missed clues in this patient. We have a high-risk patient at starting point. Diabetes is high risk, and looking at the combination of poorly controlled hypertension and diabetes confers a high-risk phenotype. Early albuminuria diagnosis, at this point, this would have been the point where the intervention would have been most promising. We can see the progressive decline, and in this case, the trajectory was simply missed. And if you are treating patients in Germany, I can tell you the problem is oftentimes you don't even have these data available for your patient. You see them and you don't have a system where you can go back and look back several years and look at the creatinine and the UACR, because simply this data is stored at some primary physician where we don't have access. The situation is different in Scotland, but we may be able to discuss a little bit of why the situation is different in different countries and why we have the problem in missing the trajectory. Okay, so I think this illustrates the problem of the situation. The problem is also illustrated by several clinical studies. Reveal CKD shows that 74% to 94% of stage 3 CKD remains undiagnosed in patients with type 2 diabetes. Only 17.5% of patients with hypertension or type 2 diabetes ever underwent UACR testing in another study. And we've seen the data from different countries. And I can again tell you for the example of Germany, my country, that UACR testing is heavily underutilized. And this is a big problem. All of you, I think most of you are very aware of the situation, but somehow we fail to spread the word to the others. And one thing that is also important to consider is the trajectory of the UACR over time. Here we have 3 exemplary trajectories, and I think it's very clear that this trajectory indicates a poor prognosis. We have an increasing UACR, which is high, and this trajectory here indicates a fairly good prognosis, but I think it's also important to look at the time course, and a falling UACR is associated with better outcomes. And this is important. So recognizing risk requires longitudinal thinking. And for this, now I brought you another patient. Again, halfway unhappy, halfway happy story. This is a young woman who was first seen by her primary physician in 2013 at the age of 32, and a diagnosis of hypertension was made. At that time, she received a creatinine, and the GFR was 65. There was no urine testing. There was no UACR testing for 6 years. She received therapy. She said that she was treated for the hypertension, but we don't know how well the hypertension was controlled. We first saw this lady in 2019 when she had developed AKI following giving birth to a child. At that time, she had a GFR of 25 and a proteinuria of 13 grams per day. Again, proteinuria had never been assessed at any time before that. And unfortunately, this is the ultrasound in 2019 from this patient. And as most of you will recognize, these kidneys don't look normal. They are small. They have a length diameter of about 8 centimeters. And the parenchyma is reduced in size. And so this is a case of an advanced form of chronic kidney disease. And we took a kidney biopsy in 2019, and we saw a diagnosis of FSGS. And there was already tubular interstitial fibrosis and tubular atrophy. There was severe changes in the vasculature, at arteriolosclerosis, we call it. We did an extensive autoimmune and genetic workup. It was all negative. So we made the conclusion, this patient, either it's a primary form of FSGS, or this is a secondary form of FSGS resulting from a long-standing, poorly controlled hypertension. And we in fact, in 2019, we made the decision this is more likely a secondary form of FSGS that we see in this patient, and that structural kidney injury had already developed at this time. Now, to end on a positive note, let's look at the data from 2019 on. This is the patient, and this is 2019. We see the eGFR shown in blue, and we see how she developed AKI, and then she received adequate therapy at the time, which at that time, 2019, was largely blood pressure targeting therapy, well controlling the blood pressure. Then later on, she received SGLT2 inhibitors starting around 2021 when the clinical studies became apparent. And you can see, and she also received mineralocorticoid receptor antagonists, this lady, but again, this was off-label, and it was used to control the hypertension. And as you can see, we were able to control her progression quite nicely. The blood pressure was well controlled. The UPCR, UACR dropped over time, and actually the GFR stabilized. She is now in a range of 35 to 40 with her GFR. So now she's 44. We have a long way for this patient. We want her to maintain her kidney function for a long time, and we need to take very good care of her. And the take-home message is, had we started earlier, had we started 6 years earlier, we potentially could have done a lot more. So my take-home message again is, assess UACR, but also interpret it longitudinally, interpret it in the context of the patient's diagnosis, and take all the other factors, such as the underlying kidney disease, into account. Interpret the trends and consider the earliest possible risk-based referral and intervention. And with this, I think it's the end of my talk, and I look forward to entering the discussion with you guys. Thank you very much.
Fantastic. Thank you very much. And I think we made that point about how do we, the importance of proteinuria. And so how can clinicians advocate for and address UACR assessment in countries or regions where it's maybe not available or underutilized? We've known that the amount of proteinuria testing across the board is not high enough, but there's also variation in regions and in countries. So what do we think we can do to try and increase proteinuria testing? Maria.
Oh, okay. To increase proteinuria testing, I think that we have, at least what we are doing now in Spain, we have a program with the Spanish Minister of Health that is a chronicity program for several diseases. And one of the important points of the program is that in patients at risk of having chronic kidney disease, we will start to test proteinuria systematically. And another thing that we have in our small region in Barcelona, it's not that small, but somehow a small region, is that, for example, if you have diabetes and if you do not have albuminuria tested, we have a kind of, for primary care, you have a kind of penalization. So this is good because you have objectives for doing your work really good. So years ago, they didn't have that, but they have a blood test that includes albuminuria if you have diabetes, and they have an extra plus at the end of the year if they are doing really good and testing albuminuria in patients for diabetes.
Yeah, maybe if I just may add, I'm very busy traveling around Germany, speaking to primary care physicians and teaching them and trying to teaching them about using UACR. And I encounter a lot of barriers. One barrier is, of course, why I don't like to treat with to deal with urine. Yeah, I'd prefer to do a blood test. So this is one of the issues. Then reimbursement is an issue. UACR testing costs about €3 in Germany. So this is an argument that I frequently encounter, that this goes on towards the budget of the primary care physician. And so we have the wrong initiatives. You mentioned incentivizing UACR testing, and we actually have an disincentivization of UACR testing in Germany. So I think these are things that can be cured and hopefully will be cured in the future.
So I think it's brilliant points. I think we would like to think that nephrologists, we are convinced about the benefits of proteinuria. We need to educate our GPs, but I think we need to educate our patients. Because patients often think, oh, if my urine is getting tested, is it because I've got a urinary tract infection? They don't realise the importance of proteinuria. They also, I think, from a patient point of view, having your blood test is, your blood is important. It's part of your lifeblood. It's an important thing. It's precious. Whereas urine is a thing that I want to get rid of. It's a waste product. Having to carry a little pot of urine through the clinic room is embarrassing. Patients don't want to do that. We've got really good in the UK slick ways of monitoring bloods in the community. We've got community hubs where people go and have their blood test done, but we don't have any community urine hubs to have people having their proteinuria. So I think making patients aware that the urine is the window to the kidney, the most important biofluid of the kidney, that the patients would come expecting to have their proteinuria tested, even people at risk of CKD.
But maybe the problem is that the patients are not aware that chronic kidney disease is important. I will be happy the day that a patient comes to the primary care doctor and asks, "Doctor, how is my albuminuria? I'm tired of listening. Doctor, how is my cholesterol?" Your albuminuria will kill you, as we show today to you. So maybe, I'm exaggerating, but maybe they need to know. And this keeps happening to me. I'm going to a plane. You are going to catch a plane, I think, just this afternoon. I'm going to a plane, something happens. We need a doctor. I say, okay, I'm bad lucky girl. Look, I'm the doctor. And they ask me, I do whatever I have to do with the patient, blah, 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 and they ask me, "Hi, how nice you are a doctor." Yes, good. What's your specialty? I say, no again. I'm proud of my specialty, and I say, I'm nephrologist. And they look at me and say, neurologist, necrologist? How come? We should spread our knowledge. Because there is a pandemic in chronic kidney disease, and that's true. But we do not know, actually. We do not diagnose enough.
So when someone on a plane has a medical emergency, we come along and go, it's important to dip the urine and test the urine. is the most important thing. Another thing, so how can nephrologists, and I think we've spoken about this already, early CKD is not a nephrology disease. It's a primary care, it's endocrinology, cardio. It's a nurse, so it's an allied health professional, so not just thinking about primary care physicians. How can we collaborate with other specialities to ensure UACR monitoring is consistently conducted across the care? Should we start with you?
So, let me add one more thing. I mean, we've already answered a lot of this, of course, with our previous discussion. But one thing that we can do is not confuse them about the kidney. And a lot of the discussions I hear are around, should I really use UACR Should I rather use UPCR? Should I do a dipstick? Should I do a micral test? You know, we have all these different types of tests, and this confuses people, and they are not sure. I think we should have a unified message. And the KDIGO decided, the guidelines decided that UACR is what we are supposed to measure. So that's what we should communicate. We shouldn't say you can also do a dipstick or you can also do UPCR. So I think that's one important point. But I see a lot of people in the audience are also having questions and potentially thoughts about this. So we should probably also involve the audience and develop new ideas how we can better involve primary care and also cardiology, endocrinology, and others. So I don't know, should we take...
Yes, because there was a girl that is already seated, so...
Yeah. Go ahead, please. Yeah.
Okay, so thank you for the amazing section. I think with all of you brought now, it's that we need to go out of our niche, our specialty. But maybe, of course, we should do a Congress for nephrologists. This is all we are all doing here. But the question is, we should to be in link with the primary care. Yes. In Brazil, we have a very good program. And right now, our Brazilian Nephrology Association is going to the primary care to give a talk to call the attention for the clinicals. And the more important is that we should maybe to do all the way around before we call invite the cardiologist or the generalist to our meeting. We should go to their meeting. This is one way to connect and people know who we are and how important is the program that we are working on. The CKD is now under the umbrella of the World Health Organization in the 5th place with the most important disease for mortality. So before the proteinuria, we don't know what happened. We don't know what happened. In my thoughts, the big question for us nephrologists, where is the first red flag in our panel of the car? What is happening before the proteinuria starts? Because we show in 1 year, they start the proteinuria from 0 to 100 something. Mm-hmm. What is going there? In our diabetic patients, for example, we have the phenotype. If we classify the phenotype, some of them, they go down to the slope of the eGFR without proteinuria. So the question for the world, maybe, we should look at the proteinuria before everything. But the question for us, nephrologists, is even before. So we should connect and congratulate, because now I think we are going out of the box to connect to the other colleagues.
Thank you.
Thank you very much.
Thank you.
So we've got a couple of questions from the audience.
There's another
another question. Okay, yeah.
Thank you. Thank you so much. I'm Cide Zorrilla from Mexico, and I would like to know your opinion on hyperfiltration with or without albuminuria as a risk phenotype for cardiorenal overload and structural stress in a nephron, rather than as simply indicating superfunction. And based on this, will you consider revising the heat maps used to define chronic kidney disease?
Okay, that's an interesting question. The question goes to hyperfiltration, yes. And a lot of patients with CKD obviously have this hyperfiltration phenotype early in their stages. You showed in your talk the fact that in CKD stage 1 you can actually may actually see hyperfiltration, which is something bad for these patients. I think where we need to address hyperfiltration very actively to the patients is when we initiate the treatment, because we need to explain to them when we start treating with ACE inhibitors or SGLT2 inhibitors or finerenone, this hyperfiltration will be corrected, and the result is a drop in the GFR. And the patients sometimes are very, or at least in Germany, they're very focused on their GFR. And if they see that my GFR was 40 and now you start a treatment and the GFR has dropped to 33, so should I, retain the treatment? Am I doing too much? I always tell them, no, this is treatment, this is a beneficial treatment effect, this is addressing the problem of hyperfiltration. And your GFR of 40 was in fact caused by hyperfiltration. Your true GFR is more likely 33. Yeah. So I think it's a very important point that we also teach this point.
But it is a hard sell for the patients, because they come and you start them on all these medicines. They're taking far more medicines than they were, and what you've done is made their kidney function worse, and that's how they see. Yeah. And it's hard to say, yeah, but your slope is reducing, and your slope was this, and they look at you as if you're speaking to them in a foreign language. And so I think this has just come back to the opportunity of proteinuria, because I say to them, look, ignore the GFR because things change, but look how much better your proteinuria is with these new medicines. And in kidneys, when I see them progressive CKD, there's not many good news stories. We're saying, we're slowing down your decline, and they say, yeah, but I'm still declining. You're like, yeah, but from us, this is a really good end point. If we can slow people's kidney function down to declining at 1 or 2 mils per year, that for us that's brilliant. But for the patients, like, I'm still getting worse. Whereas with proteinuria, you can say, look, your proteinuria has been reduced by 50 or 60% with these medicines. Isn't that brilliant? And that's a way to keep them on the medicines, and try and don't talk to them about complex linear regression slopes of GFR plots.
Thank you so much.
Thank you. Now, moving on to some questions submitted. So we've got questions from a primary care physician. So welcome to primary care physician. So they're talking about UACR, about how can we use AI to encourage patients to engage with proteinuria testing, and how do we really engage with the patients? I think that's a really important question that we kind of dealt with a little bit. Is that if the patients don't understand the importance of proteinuria, then why would they want to get it tested? So I think like you said, there's a lot of education to be done for patients. And then I guess the use of new technologies to try and encourage proteinuria testing. Do you have any thoughts on that?
Yes, if you have formulas that you are able to predict in 5 years, you have this risk to end up on dialysis. So maybe this will help with these new formulas and AI to be the patient aware that, if I decrease my proteinuria, my risk to end up on dialysis will be easier. And maybe the AI also could be used to detect, For example, imagine that you have the possibility of one patient that has glycated more than 6, that to test if in the last year proteinuria was tested. And once you detect, you send a message to the iPhone. You do not do the test in the urine this year. I think that could help us for sure.
I also think that there is a good chance in AI in terms of improving patient education. Because you all know what you do with ChatGPT. You enter your medical questions there, and a lot of people do that. And as long as the answers are correct, this will help in educating the patients on the risk profiles. And the better the AI gets in getting the right information out to the patient, including the necessity to monitor a UACR, the better. So that, I guess, again, will depend on the models and how they're trained. But I think AI is getting better, and there's a chance in that.
And for example, in America, here in Europe is less, but in America, people study a lot and go to the doctor saying, there is a new drug, there is a new therapy that I want to have. Here in Europe, I have the feeling that it's not the same, but people love AI and this stuff. I made sure that they will go and say that, and AI will show up. You can go to your nephrologist, you can do that in the future, and will help us on that. I have this feeling.
I mean, I think AI as well, or just machine learning, could looking at screening primary care databases for anyone who's on an ACE inhibitor should be tested for proteinuria. Anyone with a family history, so if there's a family history of kidney disease, that should flag up saying, test for proteinuria. Things that are, so I think we can do data mining better to trigger clinical investigations that may be of use. Great. Okay, what is the mechanism, so Maria, what is the mechanism for the strong link between proteinuria and cardiovascular disease?
Where's the mechanism?
So you've shown that proteinuria is correlated with cardiovascular disease. Do we know a mechanism between why proteinuria might lead to cardiovascular disease?
We do not know really the exact mechanism, but we suppose that when proteinuria is increased, there is a kind of inflammation. And this inflammation is driving to cardiovascular disease, to stroke, blah, blah, blah. So we do not know, but we think that is linked on that. And we are happy that at the end, albuminuria has been recognized for a risk of cardiovascular disease, because for years we have been seeing that the patients with diabetes, cardiovascular risk, that the ones that were with worse prognosis have higher proteinuria, but we didn't, it was not identified as a risk factor. And we are happy with the 5 fingers of the hand, and now that is there placed.
I totally agree. I think it's fair to say that our endocrinology colleagues know the importance of proteinuria testing, and we're getting the message out to primary care. But trying to get a cardiologist to test the proteinuria, I think that's the major struggle.
No, in Spain they are doing that.
Wow, fantastic.
They are doing. No, you know, we were in part the bad boys on that, because I remember when I was really young that a cardiologist came to me, Pepa, I measure albuminuria, and I say, oh, the patient was in heart failure, acute heart failure at that moment, do not do that. No, only when the patient is stable, blah, blah, blah. But no, do not lose the opportunity. If the patient is in heart failure, test for albuminuria. So in Spain, they are doing that pretty good. Cardiologists, not other specialties.
I want to tell one story from our cardiology department, which is a good story. They treated a patient or a patient who was treated for several weeks for heart failure. Because of leg edema, was referred to our cardiology department. And our cardiology department, what they did is they did a dipstick, and they found out that there was nephrotic range proteinuria and referred them to us. So I have to applaud our cardiologists in this regard. Yeah.
So you've got the cardiologists in Hanover are the best cardiologists in the world. I think that would be the take-home message. We've got time for one more question. So from primary care physicians have many competing priorities. Should nephrologists be taking a more active role in community CKD screening? So that's a really important question. So I talk to a lot of primary care doctors, and I'm talking about the benefits of CKD and proteinuria, and they're saying, look, that's not even in our top 10 priorities. Mental health, women's health, children, and you're coming to tell me that this is the most important thing. So it's important to be realistic with primary care, to recognise that they're under huge pressures. For us, proteinuria is the most important thing. For primary care, it's on a long list of very, very important things. And I think our job is to try and make it as easy as possible for primary care to do the right thing. So, for example, in London, we trying to get people optimised on therapies. So even just simple things like saying, don't start Ramipril 1.25 milligrams or to go up to 2.5. Give them permission to go, just start at a decent dose, 5 milligrams, or irbesartan 150. Start at a medium dose and then up titrate once, because each time you up titrate, they've got to come back. It's more of your time. They've got to have a blood test, all this. Do bigger jumps, because basically we know how busy primary care are, and the easier it can make primary care to do things like this, and they're worried, hyperkalemia. The risk of hyperkalemia is important, and we need to check it. But every time you change the dose, you should be checking the potassium. So the less dose changes you make to get them up to the maximum tolerated dose, the better. And so giving primary care permission from nephrologists to be a bit bolder in optimization and be a bit quicker. So the other thing is, thinking about SGLT2s, we know that with people with diabetes, historically people would wait for 6 months, 9 months. I'll do something and check in 3 months' time. But we know with SGLT2s, we can't wait. The benefits are seen in heart failure in a matter of weeks. So we need to get these people up titrated rapidly. So trying to get that message across to primary care, but being realistic that primary care are under such pressure, certainly in the UK, there's so much pressure with other competing things. And I think with that, unless you had any other comments, do you have anything?
I completely agree what you say, and actually, I'm not seeing any patient in my clinics with diabetes and with SGLT2 inhibitors, because we spread the knowledge in the primary care. And the important thing is, do not lose the opportunity to start with these protective drugs, because maybe the patient will not come back. So if the patient is in front of you and is at risk, treat them. This is the message, I think.
Fantastic. And with that, we would like to thank you all for coming to this symposium today. Wish you all the best and wish you happy ERA, the rest of the talks. Thank you very much.
Thank you.
This has been an activity published by Peer Voice.